Thank you. Good afternoon and good evening, audience. Myself, Dr. Rahul Mandlik, wish you a very happy new year and would like to welcome to this first webinar of 2022 on behalf of entire team of Shalina Healthcare. Samuel ran out of his blood pressure medications 2 weeks back, but unlike his HIV drugs, he never saw them as essential. And this approach might be due to commonly seen misconception across Africa that CVD is disease of rich people. It mainly affects fatty white people and Africans are immune to CVD. And this misconception might have born due to traditional belief that the major killers are communicable diseases like malaria, HIV, and tuberculosis. But today, an average African is not much aware of non communicable diseases like hypertension, obesity, stroke, and diabetes. They have rapidly ascended, and today they have become major cause of mortality and morbidity, though silently. In today's first episode of Heart Talk series, our experts are going to discuss about recent trends in cardiovascular diseases with African perspective. Before that, I would like to provide you an brief overview of Shalina Healthcare. We are an African pharmaceutical company and our operation started more than 35 years back. Today, we are one of the largest pharmaceutical companies in Sub-Saharan Africa, and since inception, our mission has been to manufacture and provide quality and affordable medicines and to make them available across Africa. And we achieve this by manufacturing our products at our own WHO approved manufacturing facility. We keep patient at the heart, and that is why we have been rolling out several patient centric initiatives like disease detection camp, treatment camps, and we strongly believe in building the core skill capability of our healthcare professionals. So, with this vision, we have launched this unique initiative of Shalina Academy, uh, just to provide educational opportunities to our doctors, pharmacists, and nurses by conducting several offline CME programs at our learning centers built across sub-Saharan Africa, by conducting regional and international webinars like this, certification programs, and by conducting academic contests and competitions for our budding professionals. With this, let me welcome our today's experts, Dr. Alfred Doku. Sir is head of cardiology at UGMS Korlebu Teaching Hospital, Ghana. Dr. Doku is current president of Ghanaian Society of Cardiology and country director at Ghana Heart Initiative. Dr. Doku has got training in cardiology from Ghana and Germany. He is a lecturer with University of Ghana Medical School since 2016. Dr. Doku is fellow of German Cardiac Society, Ghana College of Physicians and Surgeons, and he is director of African Air Ambulance Foundation. Dr. Doku has published several articles in international peer-reviewed journals. Welcome to you, sir.
Thank you.
Our next speaker is Dr. Ulunuga Olabisi. Madam is head of cardiology unit at Department of Medicine, Federal Medical Center, Obiakuta, Nigeria. Dr. Ulunuga is past treasurer of Nigeria Cardiac Society and she is fellow of National Postgraduate Medical College of Nigeria. Dr. Ulunuga is certified in leadership and management in health from University of Washington, and her areas of interest are preventive cardiology, non-invasive investigational diagnostic cardiology, and she is actively involved in international landmark projects like Remedy study, Papuco study, and Inter-CHF study. Ma'am has published several articles in peer-reviewed medical journals. Welcome to you, ma'am.
Thank you very much.
So, dear audience, today's program flow is we will have some background about the topic from Dr. Doku, and then there will be discussion between both the experts, Followed by that, I will come in towards end and take up some of the questions asked by you. So please feel free to post your queries and also feedbacks in the space provided. Thank you so much. Over to you, Dr. Doku.
Thank you very much, and good afternoon to all of you. Um, I think cardiovascular disease is a major cause of death in Africa, and we're trying to unravel the reason for all this. And we are looking at the African perspective. Why is the African dying from cardiovascular disease? We're looking at causes of death in Africa the last 50 years. It was more infectious disease based, but now we're having cardiovascular disease, which is more what we call the non-communicable diseases. So what has happened over the period? So we'll look at it in the context of the African patients and see how best we could address it. So what is the heart, or who is the heart? I think when you ask anybody in Africa about the heart, I think that the heart is one of the most feared organ in the body. Somebody can walk around with toothache, headache for several months, years, and there's no problem. The person, but when the person has chest pain, has a problem, has difficulty breathing, the person quickly goes to see the doctor because everybody has a phobia for the heart. And we all know that everybody has one heart and we need to take care of it. So the heart is so important that by the third week of gestation, the heart starts forming, making sure that it provides nutrients needed for the growing fetus. So the heart really is very, very important, and everybody knows that the heart is the focus of all activities. And if your heart stops, you would die within a few minutes. So the heart is very, very important. And then to quote Matteo Cadiz, that the heart of creature is the foundation of life, the prince of all, the son of their microbes, and from where all vigor and strength does flow. So the heart has always been the focus of attention for generations and generations yet to come. So it is important, and so let's take care of it and make sure that it continues to beat. And let's keep our hearts young. Let's keep the hearts of Africans young. Let's keep the hearts of our patients young. So with this, let me introduce you to cardiovascular disease. Cardiovascular disease is a group of diseases that affects the heart, the covering of the heart, which is called the pericardium, the muscle itself, which is called the myocardium, and then the inner lining of the heart, endocardium, the valves that, and also the blood vessels. And most often we call it circulatory disease, but cardiovascular disease is basically a circulatory disease. Any disease affects both the veins, for example, in deviated pulmonary embolism, or it can affect the arterial system, causing peripheral artery disease, cerebrovascular disease, or causing uh, uh, coronary artery disease. In most cases of cardiovascular disease, is non-communicable, and is the basic cause of cardiovascular disease is lifestyle. It's non-communicable because as opposed to TB, malaria, HIV, which is communicable, cardiovascular disease in general is not communicable. But I must say that yes, there are few cases of cardiovascular disease that can be transmitted from one person to the other, not directly. You all know of COVID now. COVID can cause myocarditis. So you can contract COVID from another person, and then this can cause myocarditis, can cause all kinds of pulmonary embolism and all kinds of complications. The same way you can get endocarditis from an infection that you acquired. You can have pneumonia, which you acquired from a patient, another person, and this pneumonia can spread to cause endocarditis. And so, but in 99% of the time, cardiovascular disease is non-communicable and is lifestyle related disease that we have. So how we classify cardiovascular disease? So there are several ways of looking at it. For the African perspective, cerebrovascular disease, stroke, is very, very important. Indeed, most countries in Africa, the mortality trend is stroke first, followed by heart disease. And the heart disease, you could have heart disease from rheumatic heart disease, where you have the valves also involved, or you could have heart disease from hypertension. You have some patients with congenital heart disease and a few with the peripheral artery disease. Coronary artery disease in Africa is very important. It's picking up. That is atherosclerotic based cardiovascular disease, which include the coronary artery disease, peripheral artery disease, and the cerebrovascular disease. But at the moment, most of the cardiovascular disease we have in Africa is driven by hypertension. As I mentioned, these diseases really very common. And so for contemporary Africa, atherosclerotic based cardiovascular disease is not very common. It's picking up. And as a cardiologist and as interventional cardiologist, I see a lot of patients with myocardial infarction who, who need an intervention, patient with infarctive stroke. Most of these diseases or peripheral artery, most of these diseases are due to atherosclerotic based cardiovascular disease. But at the moment in Africa, atherosclerotic based cardiovascular disease is not that common compared to non-atherosclerotic based cardiovascular disease, such as hypertensive heart disease, hemorrhagic strokes, chronic kidney disease from hypertension. So hypertension now is the main driver of morbidity or mortality African. And if you look at the global picture of cardiovascular disease, it's getting worse. The proportion of the global population dying from cardiovascular disease is increasing. Cardiovascular disease affects life. And if you look at the global burden of the disease, it cuts across. And if you look at Europe and America, they have cardiovascular disease somewhat under control. For the last 20 to 30 years, you have realized that cardiovascular disease burden in Europe and America is going down. And you can see that appearing as green. If you look at America, Europe, Western Europe, Australia, New Zealand, the Japan area, things are going down. But if you look at the emerging economy, the middle and the lower economy, the cardiovascular disease burden is picking up and it's really very, very dangerous. If you look at Africa now, a lot of people are having cardiovascular diseases driven mainly by hypertension. So looking at the global picture, as I mentioned, the Western world, the burden of cardiovascular disease is going down. The number of people having infarctive strokes, coronary arteries, myocardial infarction are coming down. However, when you look at Africa and in other developing countries, middle income countries, cardiovascular disease is going up. So if you look at the Western world, their contribution to cardiovascular disease probably about 20-25%. But the bulk of cardiovascular disease in the world is coming from developing countries and then middle income countries. And so there's a lot that we need to do. And so over 75%, 80% of these deaths, unfortunately, are contributed by countries that are already burdened by poverty and the development. Now they have on top of it cardiovascular disease, which is also killing a lot of young Africans and then other people in underdeveloped countries. So what is the burden of cardiovascular disease in sub-Saharan Africa? The burden for the last 25 years has been increasing. So as opposed to the Western world where cardiovascular disease affects mainly the older population, patients in their 70s, in their 80s, Africans are dying at a much younger age from cardiovascular disease. Now, what's the leading cause of death in sub-Saharan Africa? Cardiovascular disease, either the leading cause or you have some communicable diseases, But several countries in Africa, Ghana included, and several other African countries, cardiovascular disease is driving the morbidity and mortality charts. And most of the people are younger and they're contracting hypertension at a much younger age, causing the hemorrhagic stroke, causing hypertensive heart disease, hypertensive heart failure, causing kidney disease. So the burden of cardiovascular disease is that in Africa, to summarize, is that one is affecting the younger population. It's driven mainly by hypertension, and most people are not aware they have these risk factors. Most people are not on medication to control these risk factors. So it's really a problem, and it's basically a lifestyle problem. And we need to do a lot to really stop this from happening. Now, what is driving this burden of cardiovascular disease in sub-Saharan Africa? A lot going on in sub-Saharan Africa. We are moving around. There's globalization. We are copying the lifestyle from the Western world. In the Western world, they have their own lifestyle, which has been developed or adapted over several years. But the African copying the Western lifestyle really in a more uncontrolled way. So we have urbanization. People come to the cities from the villages and they don't have the best accommodation. They live in shanty towns, the suburban areas, access to basic necessities of life, basic amenities of life are not available. So they have to struggle to make ends meet. So it's very, very difficult. So there are a lot of social determinant drivers of disease in Africa, in addition to changing habits. A typical African moves to the city is not able to exercise. In the villages, he can walk several miles to the farm. But Africans, either in the public transport or have our own form of transport, and obesity is on the increase. We are physically inactive. We are taking a lot more alcohol. And some slowly are also beginning to smoke. So all these lead to the cardiometabolic renal syndrome burden that is killing Africans. So there's obesity, there's diabetes, there's dyslipidemia, high blood pressure, all these, leading to all the risk factors, that we have that lead to the heart, the heart failure, the strokes, and the kidney disease that we are witnessing at the moment. Can we prevent it? Yes, we can prevent this through lifestyle modifications and detecting the risk and doing something about it. But unfortunately, most African countries do not have 100% control of this problem. So let's look at things in more closely. If you look at Africa, burden of hypertension is very, very high. About 1 in 3 Africans have hypertension, especially the adult population. We have dyslipidemia coming up. Obesity is also coming up as we move from the villages to the cities. Lifestyle changing, physical activity goes down. We're seated all the time trying to sell one thing or the other, as opposed to when we're in the village where we walk to the farm and work on the farm. If you're white collar jobber in Africa, yes, you're also seated all the time. So the African is becoming obese, and not only the adults, but our children are even worse off. Okay, children are sitting in cars, going to school and then back. I remember when we were in the village, yes, we walked to school, walked back home. At school, we were walking around, playing football, in all kinds of sports. You hardly get somebody obese amongst us when we were children. But amongst our children now, you have a lot of childhood obesity that is coming, and that is really gives me, cause to worry about the future of Africans. This problem that we have, the hypertension, dyslipidemia, obesity, alcohol abuse, physical inactivity are going to get worse in the next few years. So as I mentioned, Africans are having high blood pressure, and the adult population really, having this burden. Um, the problem with hypertension in Africa, as I mentioned, is that it's affecting the very young people, patients in their 20s, in their 30s, in their 40s, in their 50s, as opposed to those in the Western world who would have hypertension at much older age. The hypertension in African is level is higher. The uncontrolled hypertension is higher. Most people are not aware they have hypertension. You know. It is said that about 65% of Africans have hypertension. Of those who have hypertension, they are not aware. You know, only about 35% are aware they have hypertension, and those who are aware, only about maybe 20% are on medication, and those who are on medication, or less than 10% of them have their blood pressure control. So with this hypertension which is not controlled, what happens is that it combines with other risk factors, comorbidities like obesity, diabetes, the smoking, the dyslipidemia, causing all the changes to the heart, to the vascular bed, and then causing all the, let's look at the heart specifically. There's a remodeling of the heart causing left ventricular hypertrophy, or if it causes atherosclerosis, then you're likely to have myocardial infarction. So it causes both systolic and diastolic dysfunction, eventually leading to heart failure. Either will preserve systolic function, or heart failure would reduce systolic function. And so this really, in most countries in Africa, the cause of morbidity and mortality where the heart fails, and also have stroke. The same mechanism also, good for stroke, good for kidney diseases. Let's look at the trend of cardiovascular disease for the last maybe 30, 40 years. As opposed to the Western world where you have decreasing, prevalence and incidence of cardiovascular disease. In Africa, this morbidity and mortality from cardiovascular is worsening. Okay? So, and most of them are driven by hypertension. So if you look at hypertension heart disease, this is data published by Professor Mensah from the CDC, looking at the mortality trend of cardiovascular disease in Africa from 1990 to 2013. As you can see, ischemic heart disease, ischemic stroke, hemorrhagic stroke, they are all increasing. Rheumatic heart disease is plateauing or is decreasing because of antibiotics and all that. But look at atrial fibrillation, look at hypertensive heart disease, and peripheral. These are increasing because of hypertension. And so we need to do a lot more. And the trend is increasing and increasing. So this is my last slide. I've tried to walk you through the burden of cardiovascular disease. And I mentioned that in Africa, Sub-Saharan Africa, what we are dying from is cardiovascular disease. And most of them are non-atherosclerotic based cardiovascular disease, driven primarily by hypertension and other comorbid problems from poor diets, physical inactivity, and then lack of control of these risk factors. So we're getting strokes, heart diseases, from hypertension at much younger age compared to those in the Western world. The question is, how do we reduce this trend? How do we, bring down the burden of cardiovascular disease? There are three ways we can look at it. We need to build capacity within the health system in Africa to manage them. Less than 5% of support to the health system in Africa goes to non-communicable diseases, with cardiovascular disease being part of it. Less than 5%. The bulk of the money goes to malaria, HIV, TB, now COVID, maternal and childhood. These diseases are very, very important. But we have double burden of diseases in Africa, infectious based and non-infectious based. About the disproportionate allocation of funds. And so we need to build capacity within the health system in Africa to manage cardiovascular disease. So what do I mean by capacity building? Every country in Sub-Saharan Africa needs to have a guideline to manage cardiovascular disease, guideline to manage hypertension. With this guideline, we need to develop training manuals to train health professionals how to manage cardiovascular disease. Second, we need to build, we need to have equipment within the health system, blood pressure devices, monitors. All these ECG machines should be available within the health system to manage cardiovascular disease. And then we need to have a nationwide, capacity emergency response system to be able to respond to patients with cardiovascular disease. So we need to build a capacity within the health system, strengthen the health system, to manage. Right now, the health system is more infectious based, malaria, and maternal and child health, immunization, but it's not well positioned to manage cardiovascular disease. The second, once we've strengthened this, the other thing we need to tackle is population-based interventions. We need campaigns to enable the Africans be aware of their risk of cardiovascular disease, reduce obesity, reduce salt in their food, reduce sugar in our food. Sugar now is a major dietary poison. Okay, cholesterol is not only a danger so far as diet is concerned, but sugar is a major problem. We need to change that. We need to exercise. Africans in the cities need to exercise. We need to cut down our alcohol intake. And so we need to have a population-based intervention campaigns to make people aware. And we should bring this campaign down to the children, even in school, so the lifestyle changes in schools can go a long way, because if you educate a child, this child grows to have a lifestyle that will affect his children, his family. And so we need a national, uh, you know, agenda or plan to making sure that Africans are aware of their lifestyle risk, and then guide them through how to really modify and improve their lifestyle so to prevent cardiovascular disease. The last one, which can also be done simultaneously, is to detect the risk factors. As I mentioned, um, about 65% of Africans with hypertension are not aware. Africans with diabetes are not aware. So by the time they are diagnosed with hypertension or diabetes, they have comorbid problems, and they have target organ damage. It's about 30 to 40% of Africans, when they have hypertension, detect to have hypertension, they have retinopathy, they have left ventricular hypertrophy, they have nephropathy already. And so we need to screen Africans any opportunity we have, pre-employment, regular health checks within schools, within workplace, regular health checks at the facility. If somebody comes to the hospital with a toothache, blood pressure needs to be checked, blood sugar needs to be checked. If somebody comes in for delivery, whatever opportunity we have within the health system, we need to screen patients for cardiovascular disease risk factors. So with this, I think we can go a long way to making sure that yes, we can address cardiovascular. But if you don't do this, then the burden of cardiovascular disease will continue to rise. And of course, every country in Africa should have the capacity to pay for medication. Because after the diagnosis of hypertension and the patient cannot afford medication, it becomes a problem. So the national insurance system in every African country should work to be able to take care of the poor, to take care of the marginalized in society, so that they can afford their blood pressure medication, their diabetes medication, and other medication that they need to control cardiovascular disease. So this is what I want to share with you, that cardiovascular disease is a major problem in Africa, and is driven by hypertension, and is affecting people at a much lower age. Thank you very much.
Thank you, Dr. Doku. I don't know if you can hear me now, Dr. Doku.
Yes, I can hear you, doctor.
Okay, thank you for that wonderful lecture on cardiovascular disease. You went to town to tell us about the effects in Africa. I want to ask you some few questions on cardiovascular diseases, especially in Africa. Can we say the complications we see concerning cardiovascular disease in Africa is different from the one we see in the Western world? Is the myocardial infarction of Africa the same as myocardial infarction of the developed world? Is the hypertension of Africa the same as the hypertension of the developed world? Are all these complications that we see making up cardiovascular diseases, can we say they are the same, or ours is a bit different, or we have one magic in Africa that is preventing those complications from coming up for us? Then the age you talked about, you also told us that the age of incidence of cardiovascular disease in this part of the world occur at a younger age. What is the relevance of this when you have cardiovascular diseases occurring at a younger age? You also told us that the death from cardiovascular disease, you have it occurring, um, over 75% of these deaths occur in developing countries, of which Nigeria, Ghana, most of the sub-Saharan Africa are one. You have these deaths occurring in younger age group. What are the implications for us in Africa? You also told us that we see these cardiovascular diseases increasing in Africa compared to the developed world, where we see the prevalence, the incidence reducing. What can we do? You've told us some of the things we can do. Where are we doing well? Where are we not doing well?
Okay, thank you very much, Dr. Olunuga. Cardiovascular disease is cardiovascular disease, but it's a spectrum. Okay, so we in the developed world, Western world, this also started with non-atherosclerotic based cardiovascular disease, where they had rheumatic heart diseases, they have infectious based cardiovascular disease, and then they had hypertension driving cardiovascular disease. They were able to control some of these determinants of this non-atherosclerotic big cardiovascular disease. And slowly they're having atherosclerotic big cardiovascular disease. They're living a bit longer. Unfortunately, our type of cardiovascular disease is non-atherosclerotic based. Atherosclerosis in Africans is going to increase over time, but at the moment, the predominant determinant is non-atherosclerotic base. And so what it means is that Africans are dying a lot more from uncontrolled hypertension, okay, which is driving the stroke, which is driving the kidney disease, which is driving the heart failure and the heart disease and the aortic dissection. And so that is where the problem is. And so that is a bit different. And then the other difference is, as I mentioned, we are getting these diseases in a much younger patient. Today, I did echo in 18 patients, and those who came with hypertensive heart disease, most of them were in their 40s, some in their 30s. In Europe and America, you will see this in patients in about 70 years who have heart disease. So Africans are getting these diseases at a much younger age. And we are also dying from this disease at much younger age. So typically in Africa, you see obituaries around, oh, gone so soon, what a shock, And this because these people die from hypertension, which they go to school or they go and do their normal things, and nobody thinks the person is sick. And then suddenly you hear the person is so that is where the problem is, that Africans are dying from cardiovascular, which is mainly due to uncontrolled hypertension. And the age, group of people who are getting this is much lower compared to those in the Western world. And unfortunately, we don't have a system to control cardiovascular disease properly, as I mentioned in my lecture. And so Africans are burdened with the disease, and there's really no system to control it. And so we need to build that capacity. We need to change our story, and then the lifestyle is also driving a lot of the problem, where Africans are moved to the cities, and then we're getting all this. Africans get to Lagos, for example, or to Accra, or to the capital of most of these African countries. And the first thing is survival, and the survivor, the person will do anything. The person doesn't have proper accommodation. The person has to do any job to be able to survive. And these people, when you look at them, health is the least on their mind. And these are the people who are carrying high burden of hypertension in the shanty towns, in the slums. And unfortunately, you see them come down with hemorrhagic strokes, and they were not even aware they had this hypertension. So it's really a bigger problem that we need to address. Thank you very much.
Thank you so much, Dr. Doku. You have mentioned most, we'll come back later to the prevention of cardiovascular diseases at the three levels that you mentioned. We'll come back to that later. But let's first go to the risk factors for cardiovascular diseases that you mentioned. You've mentioned quite a lot. Can you cone down on the big four or the big five cardiovascular risk factors for us in Africa?
Okay, thank you very much. So when you look at cardiovascular disease, there are modifiable and non-modifiable risk factors. Unfortunately, we think that okay, the non-modifiable risk factors, we don't need to do much about it. It has to do with my gender, my age, has to do with something I've inherited from my family. But it's important to know. You need to know your risk factors. You need to know, what can kill you. Africa, we think that okay, when we don't know, it won't kill us. No, just as in law, ignorance is not an excuse. If I don't know I have hypertension, it doesn't mean I can't die from hypertension. So we need to know what killed our mother, our father, what my mother has, what my father has, what my siblings have. So if my father has diabetes, I may also get diabetes. If my mother has diabetes, we need to know this. So we need to know our family risk factors, and then guide ourselves against it. So we need to know what is within the family, and then our own personal risk factors. We need to do regular checks to be able to detect some of the big four or five that we mentioned. One is hypertension. Hypertension is very, very important. That we need to know, check our blood pressure very frequently to be able to address it if it is. We need to check our blood sugar levels. We need to know whether it's normal, whether it's impaired, or it's within the diabetes range, and then see what we can do. Cholesterol level, we need to know our lipid levels to be able to address the triglycerides, the HDL, and then the LDL cholesterol. We need to know this. And then having done that, we also need to profile ourselves. Do we smoke? Do we take alcohol in excess? That is also very important. But another thing that we ignore in Africa, if you're obese for a woman, that is beauty, but it comes with all kinds of problems. We hardly diagnose obesity in Africa as a problem or as a disease, but we need to, because it drives the metabolic syndrome. So that is very, very important. Now, says that we exercise, because not exercising in Africa is also a major risk. So these are the things that drive cardiovascular disease in Africa. And then the number one, number two, number three is hypertension, and the diabetes, the metabolic syndrome, the dyslipidemia, the obesity is a common thing in Africa. And if you go through most cities in Africa, you see women and men very obese, sitting down, selling one thing or the other. And you ask, well, when was the last time you checked your sugar? I haven't done that. So these are the risk factors driving morbidity and mortality across Africa. Thank you.
Thank you. So, number one, hypertension. Number two, hypertension. Number three, hypertension. All the others are four and five. That is what Dr. Doku is telling us. So, why is this hypertension that very important? You need to note that for us in Africa, hypertension is, for over 90% of people, is symptomless. They don't have any symptom. When you have malaria, you have headache, you know you have a problem. And by the time you take drugs for 1 or 2 days or 3 days, you are okay, you've treated your malaria and it's gone. But for this hypertension, you don't have any symptom. And one doctor is telling you to be taking drug every day for a symptomless condition. And you have just told us that hypertension is one, hypertension is two, hypertension is three. Why is hypertension very, very important?
Okay, thank you. I will summarize the hypertension. I always said a silent killer. Okay, it's a silent killer. And if you are lucky, hypertension will send you to the hospital because it's causing a headache or palpitations or chest pain or easy fatigability. Now, if hypertension is giving you palpitation, easy fatigability, it is possible it's caused damage to your heart already. So the majority of patients really they are not aware. Indeed, as I mentioned, when an African is diagnosed with hypertension, about 35% to 40% have some complications already. So hypertension is important because in the majority of patients, they don't have symptoms. If they had symptoms, for example, malaria, they had COVID, or they have respiratory tract, they will go quickly run to the hospital. But hypertension can go on, and I see a lot of patients in it's similar across Africa, where somebody is diagnosed with hypertension for the first time. You look at the person's heart has gone through hypertensive heart disease, all the stages to the end stage, you know. Recently, a neighbor were called to take care of a neighbor who had difficulty in breathing after delivery, and then we brought her to the hospital. And a very young lady, and ejection fraction was 22%. And blood pressure was 178 over 137. And she went through antenatal care. The nurses checked the blood pressure. Yeah, at times they say, oh, she's stressed, that's why the blood pressure, but nobody actually told the young lady that she had hypertension that needed to be controlled. She actually went through cesarean section. Nobody told her anything. And then about 6 weeks after delivery, now she went into left ventricular failure, only for us to find out that the heart is so weak. And that is the typical story of hypertension in Africans, where there's no symptom, and so it makes hypertension really very dangerous. And hypertension, once it causes some of the complications, it cannot go back. They don't reverse. So this weakened heart, at that threshold, once it is crossed, you can control the blood pressure. The heart cannot remodel back to normal heart. The same way, if you have retinopathy from hypertension, it gets to critical stage, you cannot reverse. The same way, when you have CKD from hypertension, you cannot reverse. So that is why hypertension is really the main risk factor, because people are not aware. People do all kinds of things, but they don't have any symptoms until they get to that critical stage where they get symptoms, and it may be too late to reverse things. Thank you.
Thank you very much. So we now know that hypertension most of the time is symptomless, and that is the reason why we should measure blood pressure at every given opportunity. Husband following wife to antenatal, we should use the opportunity to also measure the husband's blood pressure. Okay, having said that, at what blood pressure would you say somebody is hypertensive? And what are the different ways of measuring that blood pressure?
Okay, thank you very much. So, diagnosis of hypertension and the relevance of hypertension is in two ways. Okay. You can look at it by the actual measurement, the value that you get when you measure blood pressure. So, let me make it simple. There are several guidelines out there: the Americans, the Europeans, the British. Some even have the Canadian, the New Zealand. You have the Australian. But I think the consensus across all these guidelines is that blood pressure of 140 over 90 is high. And so from 140 to 160 will more or less be what we call the stage one hypertension, and then diastolic 90 to about 100, and then from 60 to 180 maybe stage two hypertension, and above 180 we say is a stage three hypertension or severe hypertension. Um, so we could say that, and this is office blood pressure measurement. This is when somebody takes your blood pressure in the hospital, then you can see this is so if this is the measurement, then you can be tagged as hypertension. Once we can confirm this consistently within three measurements. So hypertension is not defined as hypertension until you can confirm over a period of three measurements. One, the person needs to rest very well. The person should have had probably a good rest, and then you measure the blood pressure. The patient is well relaxed, and then you measure. And ideally, we should use the automated machine to measure. So once you can measure this, maybe on three different locations, it's confirmed that this average is this, then you can see the person has hypertension. You can classify as stage one, stage two, or stage three hypertension. But hypertension value itself is not as important as the comorbid problems. Is this person diabetic? Is this person has this lipidemia, has this other problem? So you need to make know risk profile this person. And so even though the person blood pressure is 138 over, let's say, 84, yes, if the person with diabetes really is at a risk of developing atherosclerotic cardiovascular disease because of this value. So there's a blood pressure measurement that you can classify as it, but if you look at the person comorbid problem, then the same way, if the third thing you need to look at, so the one is the measurement, and then the second one is the comorbid, and then the third one is the target organ damage. Now, if I examine the patient who has hypertension, the eye, and I see that the retinopathy, there are changes due to hypertension, even though the person's blood pressure 135 over 85, I'll be worried. I may probably want to intervene. You know, there are a lot of Africans who probably started with blood pressure of 90 over 70. And then you see at a point where the blood pressure is 135 over 85. Yeah, you will not typically classify this as hypertension, but if you look at the target organ damage, there's kidney damage, there's heart problem, then it means that the change from 90 to 135 has been going on for a long time, and it's very significant. And so you may want to do something about it. So in looking at hypertension and diagnosing a patient with hypertension, you need to look at the definition, you need to look at in terms of what you get in the terms of measurement, you need to look at other problems that the patient have in terms of comorbid problem, and then you need to look at the blood pressure, the complications from that. And so there are three ways of measuring blood pressure. You could measure blood pressure at the hospital. The hospital blood pressure measurement really is difficult. The environment within the hospital across Africa is not convenient for a lot of patients. You know, we shout on these patients. Some of the patients come and wait for 6 hours, 7 hours before they are seen in the hospital. Some of them cannot even get up to go to the washroom, because they don't know when they're going to be called. So at the time you measure the blood pressure for an African in the hospital, the blood pressure in itself is high, not because it's that high, but because of the environment that the person finds. Africans travel several miles to come to the hospital. So the hospital blood pressure measurements, the definition of it and the classification is what I've mentioned. But I think the best way to measure blood pressure is what the patient measures at home, we will call the home blood pressure monitoring. And so most Africans have been encouraged to own their own blood pressure machine and measure in the morning before, if they are on medication, before they take their medication, and then they can check it also several times in the day, and that will give you an idea what readings are. But the readings in the hospital, even though they're relevant, the best would be to use the one that is being measured at home. Of course, there's ambulatory blood pressure measurement where we actually mount this device, and then the patient goes home with it, and then every hour, every 30 minutes, it's checked. This is relevant for some selected patients, but unfortunately, this is not easily available across Africa. But I think what we should encourage our patients is to monitor blood pressure at home. Even if there's a pharmacy shop around their house, I think that environment is more convenient for them than the hospital environment, and then they can check it, and then they can bring. So that for me is how blood pressure measurement should be and how blood pressure should be diagnosed. But I think it will also be important to know what the blood pressures were so that you can compare. So the patient who comes with blood pressure 134 over 85 from 90, there's a significant increase, and that can cause a lot of problems. Thank you.
Thank you very much, Dr. Doku. So, from what we have heard now, we know that home blood pressure monitoring is very, very important for our patients, especially in our patients with what we call white coat hypertension or white coat effect, as the case may be. And we also have the masked hypertension. I'm sure during the question and answer period, Dr. Doku, they will be asking you. But because of time, I want us to move forward to other things. And of course, you have also told us that the number is not absolute, because the blood pressure is more than 140 over 90 or is less than 140 over 90 does not mean that patient will not require medication. It depends on hypertension mediated organ damage, and is also dependent on the other cardiovascular risk factors that this patient may have. Now let's go to the management of the hypertension itself. We know that in the management of hypertension, we have two things to do: the lifestyle modification and the medication. I want us to start with the lifestyle modification and take them one after the other, because they are actually, who should have lifestyle modification and what should we do for each one?
Okay, thank you very much, Doctor. I think lifestyle modification is important for every African, whether you have hypertension or not. And as I mentioned in the lecture, that is one thing that we should all, every country should aim at. There should be a national campaign aim at, educating the public how to reduce weight, how to cut down salt, how to reduce alcohol intake, how to stop smoking, how to exercise. I think that for me is important for our patients across Africa, because the metabolic burden in Africa is so high, and that is driving, causing insulin resistance, and through that you get hypertension, you get diabetes, you get all the problems and atherosclerosis that comes with it. So lifestyle modification is very important. Now let's zone in on hypertension. Every hypertensive should have lifestyle modification. Now, the lifestyle modification is important to making sure that yes, the person, is able to reduce weight, because reduction in weight is able to reduce diastolic and systolic blood pressure significantly. Cutting down your salt intake reduces your systolic and diastolic blood pressure. Reducing alcohol intake also reduces your blood pressure. And then exercise. Now I have to be careful here. I've seen across Africa patients with very high blood pressure, some 200 over 130, are told to go and exercise. The doctor said, look, go and then exercise so that your blood pressure will come down. And what happens? Somebody with blood pressure of 200, 130, for example, diastolic, now goes to exercise. During the exercise, blood pressure now goes to 320 over 150, and the person dies suddenly from a stroke. And then everybody said, yeah, exercise killed the person. No, exercise did not kill the person. It was the person who gave that recommendation. So exercise is very important. And it's also important that when somebody doesn't have the capacity to exercise, the person is not accustomed to exercise, then the person should have an initial review, blood pressure checked. In this case, the person has hypertension already, and then the person's maybe called auscultation, does the person have any problem before you prescribe. And then exercise should be graduated. You can start with few minutes a day and then gradually increase the intensity. And so exercise is important. Exercise has been shown to reduce systolic and diastolic blood pressure. And the smoking, you have to stop smoking. And then let's see how we could also modify our lives to be able to accommodate stress, cut down the few things that we can reduce. One thing about culture in Africa is about the social engagement. And at times it can create a lot of problems for us. So let's see how ones that we can reduce. Weekends, you see Africans at several engagements, several activities, and then during the week, then they engage in their formal occupation. At the end, the African doesn't get time to rest. So I think these are a few things that can be modified, and then to making sure that the blood pressure is reduced, and that it cuts across. But I'm warning, and I want you to also take this up to your patient, that when the blood pressure is moderate to severe, the exercise recommendation should be, should be toned down until the blood pressure is well controlled, and then the person can go on and then gradually increase the intensity of the. So lifestyle modification is important to reducing blood pressure, and that alone can decrease diastolic blood pressure by about 10 millimeters of mercury or more, and then the systolic blood pressure of about 20 millimeters of mercury or more. But certainly that is important, and it should be preached across board. Even as I mentioned, our school children should all be involved in lifestyle modification. Of course, when the person has hypertension, this is very important to reducing the metabolic syndrome, to reducing all the risks that cause cardiovascular disease from all these risk factors. Thank you very much.
Thank you, Dr. Doku. And of course, our abdominal obesity in Africa, we always believe that if you have a big tummy, you are rich, you're wealthy. And our diet, especially the use of palm oil in this part of the world, where you want that palm oil to be swimming on top of your soup, all of that we need to take cognizance of and
Oh,
mind them. Because of time, let's go on to our drug management.
Adrian.
Which drug can we give to an hypertensive, and how do we give them?
Yes, thank you very much.
And when do we give them?
At the
The
African
how,
with
the when,
the
the
African
which.
with the pot belly, Africa with the pot belly, yes. It's a hot cake for some women because then that man can take care of her and can take care of the children, you know. And so I think that's something we can reduce. And then just back to this diet. I think I mentioned in my lecture that look, carbohydrate is a poison now. You know, in the past, the emphasis was on fats, but now carbohydrate, the liver can take up to 100 grams of glycogen. And so when you take a fatty meal, a meal containing a lot of carbohydrates, and in Africa, carbohydrate is really is the base of everything we eat, from eba to the in Ghana, if you fufu and several
Mhm.
other places. Yeah, the carbohydrates is the main thing, and so we need to cut down on carbohydrates because then it increases our risk of developing diabetes, obesity, and all that, because the liver cannot store more than 100 grams of glycogen. So the rest now goes converted into fats that cause abdominal obesity, cause the obesity in general. So we need to watch the fats, the carbohydrate we eat, and also try and then reduce our weight. Now the medication. I think we have enough evidence to show that medications work. So lifestyle modification is key, but the medication for some patients. So having measured the blood pressure consistently and confirm that this is the average blood pressure, and having risk profile the person, whether the person has diabetes, has high cholesterol, has this or had, and then also having screen to be sure that the person has this problem, has that problem in terms of hypertension mediated target organ damage. Then we need to look at all this in totality and look at what medication will be best for the person. Now let's look at a typical hypertensive whose blood pressure is maybe 165 over 100, who is not diabetic, doesn't have this lipidemia, doesn't have a heart disease, hasn't had a stroke, hasn't had a kidney disease. Then this person, the recommendation is to start two drug combination, for example, at low doses. So you could do amlodipine with a thiazide diuretics, for example, hydrochlorothiazide. You could do um, several other thiazides that are on the market, and it starts with small doses, or you can do a diuretic with an ACE inhibitor or ARB. Start with small doses combination, and then slowly monitor the blood pressure. Now, the importance of starting two drugs at the same time, at small doses, is that one, you're able to have synergistic effects. Means that 1 plus 1, that's one, the effect you get from one drug, and the second drug, if they combine them, they have more than two. 1 plus 1 is supposed to be two, but they have more than, so you have a much, significant blood pressure reduction. And when you have a combination therapy, also there's compliance. If a patient is taking blood pressure medication, it takes the amlodipine in the morning, it takes the hydrocortisone in the afternoon. The chance of forgetting the afternoon one is high. But if it has a combination, one drug that the person can take at a go, and then forget, and then go on with a daily activity. So let's look at the blood pressure level, let's look at the comorbid problem, let's look at the target organ damage. If a patient that the lady I mentioned who has heart failure from hypertension, of course the blood pressure is high, the heart is also weak. Now, then I have to manage this person's blood pressure and also have to manage the heart failure. So there are several medications that will come on board, to manage the blood pressure. And there's a common drug that is good for heart failure management. The quartet, or the three very important. Some call them the four wise men. Some which are important for heart failure management. Some of these drugs are also very important for hypertension management. So your beta blocker, your ACE inhibitor, ARB, your diuretic. Here you're looking at plenarone or spironolactone. So having done this combination, and if the blood pressure is still high, then you can go on probably up titrate the ACE inhibitor, ARB. Amlodipine for a weakened heart is not very much recommended. So or the calcium channel blockers for a weak heart is not very much. So you need to look at your blood pressure, you need to look at the target organ and comorbid problems, and then give the appropriate medication. But as I mentioned, combination therapy is key. In this combination, we're looking at thiazide diuresis, we're looking at a calcium channel blocker, we're looking at ARB or ACE inhibitor. And then if the person has heart failure or other problems, then you bring other drugs like a beta blocker to the combination, to making sure that yes, the other comorbid problem, target organ damage, also very key. Now, if the person is diabetic, then type 2 diabetes with hypertension, then your ARBs are very much recommended, or ACE inhibitors are also very important in these. So yeah, look at all these, and then you of course, if a patient has left ventricular hypertrophy, ACE inhibitor ARBs have been shown to redress the hypertrophy even faster. If somebody with a renal failure, early stage or CKD, for example, your ARBs are also very important. So look at the blood pressure level, look at the comorbid problem, look at the target organ, and then choose the appropriate one. But if the person doesn't have any of this comorbid, and then you can go to this four drugs that I mentioned: ACE inhibitors, ARBs, the diuretics, and the calcium channel blockers. And ideally, start with a combination, small doses. I'm loading maybe 2.5 or 5 milligram with the thiazide diuretics, and then monitor the blood pressure. And then you may migrate to a three-in-one medication, where one drug contains calcium channel blocker, contains ACE inhibitor, RAB, and a thiazide diuretic. That also is something that can be given, especially for moderate to severe hypertension, to get a better control. And one good thing about these three-in-one is that there are several permutations where you can give higher doses of amlodipine, higher doses of the ARB, and then higher doses of thiazide. So these permutations are available to adjust. So that at the end of the day, the person has three drugs, but it's also taking only one. Or for combination, for drug combination drugs, where they are taking two drugs, but just two medication, but just one drug that they are taking. So these are all available on the African market that you can, get a patient, so that it improves compliance. Compliance is key. And also cost, it brings down cost. So you're going to buy three drugs instead of different drugs. Then if you're buying just one, the cost of the one which contains the three is far better than the one when you're buying them individually. The same with the two-in-one combination, at the end of the day, is more cost effective than buying individual medications. So a combination is key, improve compliance, it is better blood pressure control, and in most cases also is more cost effective. Thank you very much.
Thank you very much, Dr. Doku. So we now know that single pill combination of minimum of two drugs for the management of hypertension. Most cases of hypertension will need single pill combination containing minimum of two drugs. That has come to stay in the management of hypertension, and Dr. Doku has brilliantly told us how to go about it. And of course, we know cost is also an issue, especially in this part of the world. Complications, the side effects of those drugs are also issues. Those are some of the things we need to put together, because we know that this patient is going to be on this drug for a long time. So we want to, at the onset, give the patient a drug that the patient will be able to continue with, which is actually very key in the management of hypertension. Having said this, Dr. Doku, I want to go to the common complication cardiovascular disease that we have in this environment, which is stroke. We see more of stroke than even the coronary artery disease in the developed, that they see more in the developed world. How do we manage hypertension in the context of stroke? And this brings us to another question. When should the primary physician refer an hypertensive patient to the specialist? Two questions: the management of stroke in the context of hypertension, and the management of hypertension in patients with stroke, and also when to refer an hypertensive patient to the specialist.
Okay, thank you very much. This is a very important question. I always give this analogy as when you go to the kitchen and you realize that the tap is overflowing and then there's spill of water on the floor. The first thing you do, naturally, is to close the tap and then go and look for a mop to mop the floor. Okay. I don't think at the moment African have the capacity to manage stroke. Most African centers don't have the capacity or a system to, detect stroke even at the lower level. They diagnose it properly and then manage it properly and save life. Some lives can be saved. I mean, strokes cases. But the reason I brought the analogy of a tap that is overflowing in the kitchen is that it is more cost effective for Africans to prevent stroke than to manage stroke. Because one stroke case, I mean, 2 days ago, I lost a patient, a young person, 41-year-old, to hemorrhagic stroke, And this patient is being managed in a tertiary facility with everything there. We lost that patient, So the same way goes to heart failure from hypertension, kidney disease. If you come to most hospitals in Africa, half the wards at the medical block are now for kidney failure patients, and a significant number stroke patients. Okay, so it becomes difficult, and some African, for example, only 10% of our patients with end-stage kidney disease can afford dialysis, and then and for the first year, and then as the year go by, they are not able to continue, you know, and only a small percentage can actually even continue to have, let's say, transplant. So the best way is to close the tap, and closing the tap is let's manage hypertension very well. And so that will be the best way. So before I can talk about management of stroke, we need to prevent it in the first place. That is the easiest way. And so we need to have that population-based intervention. If you're given the chance to do screening at church, let's take that challenge, screen and advise. Let's detect hypertension in the community and link them to care. Let's have a national system to detect hypertension in the community, because the taxi driver who has hemorrhagic stroke, who has 4 or 5 children with hemorrhagic stroke, the breadwinner who is just 38 years, the effects, I can't guarantee that this person goes to the hospital in Nairobi, for example, the Kenyatta Hospital in Nairobi with a hemorrhagic stroke. That person can survive. I know in Europe, a lot of people with stroke end up dying. And so even when it comes to the resource poor environment like Africa, we may not be able to manage a hemorrhagic stroke. So let's try and prevent it. Now, if you have a hemorrhagic stroke, you have an infarctive stroke, this is no longer something that you can manage at the periphery. At least the secondary level facilities and tertiary level facilities is very key. So the key thing about stroke is to suspect it, and the imaging. You can only manage stroke when you know what is causing the stroke. Is it a hemorrhagic stroke? Is it an infarctive stroke? Is it even subarachnoid hemorrhage? Because if you don't know what is happening in the brain, you can't really manage very well. But if there's a hemorrhagic stroke, the line of management is different. If it's an infarctive stroke, the line of management is different. If it's a subarachnoid hemorrhage, the line of management is important. So strokes are killing a lot of Africans, but we don't have the capacity. And the diagnosis is by suspecting them, and second by confirming with a scan, an appropriate scan. Of course, if you have an infarctive stroke and occurs within a short period of time and you do a CT scan, you may not say it. So probably an MRI will be the best way. And then depending on what it is, then the appropriate medication now come in. I think this forum will be difficult to just walk us through how to manage subarachnoid, how to manage infarctive stroke, how to manage hemorrhagic stroke. But I think what the key message for me that we need to really adhere to is that we need to prevent strokes, and then we need to diagnose stroke through imaging and then link them to the appropriate care that are available within our country. Thank you.
Okay, thank you very much, Dr. Doku. Please, for how long should we manage hypertension?
Yes, hypertension management and the power is no longer with the doctors, it's with the patient. Okay, so home blood pressure monitoring is key. Now, hypertension management is more or less for life. But what happens typically in Africa is that the primary physician, you know, even in the tertiary facility, is not frank with this with our patients or with our clients. If a person's blood pressure is high and you know this person, the previous person did not have the blood hypertension, you cannot just say, oh, it's because of stress, because of your wife or your husband, or because of your new job, you know. So you take this blood pressure medication for 2 weeks and then you should be okay. Okay, and I unfortunately this happens a lot in Africa where we're giving medication without appropriate education. So education of our patients who have hypertension is key. I know our hospitals are flooded or choked with patients, so we don't have that contact that we need with our patients, you know. So our nurses are also busy, they cannot, but let's get the opportunity. I mean, somebody who is diagnosed with hypertension for the first time, spend some minutes explaining it to them. This is a disease that it may not give you symptoms, but you may die from it, and so you will need to take care of it. And that if this disease start giving symptoms, it may be too late to reverse the symptom. So you need to the patient needs to understand. Those who are educated can probably go and read. You can tell patient to talk to the relative, to their grandchildren, to Google and get some information on hypertension for them so that they understand. So education is important, and then letting them know that yes, the intervention, both lifestyle and medication, may be for life. And then the medication also, once they are on it, if you take the blood pressure medication off, there's a rebound effect where the blood pressure when you started it may go up higher than what you started with. So it is important that education is given, that the person may take the drug for life, and it helps also with planning and trying to, budget for the medication. If they don't have money, they can, ask relatives that look, I have to be on medication for certain for life, so they can apportion and see, okay, how do I manage it? But if we talk these patients and tell them, oh, blood pressure, it's just for a short period, just take this, then becomes a problem. So I think it's for life. And then what guides us in terms of the dosages of the medication, when to reduce and when to increase, is when the patient is monitoring the blood pressure at home, comes in. For example, if the patient is taking the two drug combination, single pill combination, and maybe the patient is taking amlodipine 10 milligrams and then hydrochlorothiazide 12.5, or let's say 25 milligram, the person comes and the blood pressure is low, you can adjust and take maybe amlodipine 5 milligram, hydrochlorothiazide 12.5 milligram combination, and then adjust. So you adjust depending on the blood pressure, but to tell the person that okay, you stop is a problem. We need to guard against it. And the education, even is 2 minutes, it will be an important thing. Thank you very much.
Thank you very much, Dr. Doku. For the few minutes we have left, I'll just ask you this question. I think I'll just ask you two more questions, but this one now, then one question later. We know that most of our hypertensive patients, they also have other cardiovascular risk factors apart from the hypertension. So let's talk about dyslipidemia. What is dyslipidemia and how do we manage it?
Okay, thank you very much. So in the past, we say hypercholesterolemia. So that was the term in hypercholesterolemia. But it's now dyslipidemia. But dyslipidemia because there are several things that can go up, which may be abnormal or can go low. So if you have low HDL cholesterol, that is dyslipidemia. If you high triglyceride, that is dyslipidemia. If you high LDL cholesterol that is high, that dyslipidemia. So dyslipidemia is really high levels of these uh, cholesterol related chemicals in our blood. These are very, very important, but they are also risk for atherosclerosis. So if you look at this lipidemia, think of atherosclerosis. Atherosclerosis-based cardiovascular disease is driven by several factors, one of which is a high cholesterol or high low HDL cholesterol. So that is what it is. Now, there's been a lot of controversies over the past 5 years in terms of diets and dyslipidemia. Most dyslipidemia cases in Africa, but close to 80% of them are inherited. Okay, and so diets in itself may not be the main contributor to dyslipidemia in Africa. And so when you have dyslipidemia, it may be something that runs in family. I have several patients, very slim, they eat well, everything is okay with their lifestyle, and cholesterol is so high. So don't blame your patient with dyslipidemia. You know that oh, you've been eating the wrong thing, you've been eating too much egg. No, let's address it. You know that it may be something that is inherited, and that and then address it, and give the person appropriate therapy, diet, lifestyle modification, as well as the appropriate medications which are on the market. So we have the rosuvastatin, we have the atorvastatin, simvastatins that are there. But again, therapy for dyslipidemia is dependent on the person's risk factor. So my target for LDL cholesterol will depend on what this person has, in treating the person with dyslipidemia. So there's moderate intensity, high intensity statin therapy, but that is dependent on the person's, risk factors, the person's chance of having an event. For example, I'm an interventional cardiologist, and if I see a patient with who has myocardial infarction and putting the stents, this is a person I have to give high intensity statin to, and I try to achieve LDL level of maybe 1, or even now it's recommended 0.8, so depending on the person's risk factor, but anybody who's had an infarctive event, for example, peripheral artery disease, cerebrovascular disease, infarctive cerebrovascular event, or infarctive coronary artery disease, then you're making sure most of these are due to atherosclerosis. So you make sure that you give the appropriate high intensity statin. Rosuvastatin and atorvastatin are very important statins on the market that you can give to your patients. In terms of dose potency, I think rosuvastatin is way ahead of atorvastatin, and so you can give atorvastatin 40 to 80 milligrams, and you can give rosuvastatin 20 to 40 milligrams, depending on the person's risk and then what you hope to achieve. So this lipidemia in Africa is very important, and it drives atherosclerotic-based cardiovascular disease. Thank you.
Thank you very much, Dr. Doku. So the myth that if you are slim, you cannot have dyslipidemia is not true from what you
No,
have just told us.
yes.
Thank you very much for that. I'll just ask you the last question because of time, and I'm going to put many things into this last question. What is the role of our cardiac societies, PASCA, and the government in reducing cardiovascular disease?
Okay, thank you very much. So, I think, as I mentioned, cardiovascular disease and non-communicable disease, they're not receiving the necessary attention for international partners, and they're also not receiving the necessary attention from government across Africa for obvious reasons. Whoever is donating money or supporting your health system has its own interest. And most people are not interested in cardiovascular disease, and so the national societies and the regional societies, and the African overall the African body, which is the PASCA, it has an important role to lobby, you know, lobby the agencies, lobby the national system, lobby the health system to be able to bring this change. So that role is very, very important, because if they don't do it, then nothing is done. And let me give you an example. The Nigerian Society of Hypertension, Cardiac Society, has done a lot coming out with guidelines, lobbying to get certain drugs into the system, to making sure that certain medications are easily accessible to Nigerians. We have the Kenyan Society, 2018 came out with a guideline with other partners. We have the Ghanaian Society came out with a guideline and training and several other things. So the national society, the regional societies, and then the African society, very, very important to bringing some kind of attention to cardiovascular disease, and then also leading the way to bringing interventions, the guidelines, the training manuals, the training, the equipment, the necessary medications that can be procured, for heart failure, for stroke, for heart diseases, and atherosclerotic cardiovascular diseases. Heart failure disease now has a lot of medications, and we need these medications in the system, and then it's the societies that can also lobby. So I think the societies have a very important role. Some have done a lot, others are sleeping, unfortunately, but we should all wake up and making sure that Africans, as I mentioned from the beginning, are dying. And it's the only society, the society that can really get everybody on board to help the situation. Thank you.
Thank you very much, Dr. Doku. Advocacy is key for our
Yeah.
societies. Thank you so very much. So I'll hand over to Dr. Rahul Madlink.
Thank you so much, ma'am, and Dr. Doku for such an insightful session. I can understand it is such a vast topic, and it is very difficult to cover so many things in short time. It is just in 1 hour. I really appreciate both the speakers for covering many areas, particularly hypertension, as Dr. Doku has emphasized that in big five, number one, two, and three are the hypertension. We heard you very clearly and loudly. Uh, Particularly, Dr. Doku, I'm sure your tips regarding the diagnosis part of hypertension are going to help our audience in a big way. Like for blood pressure, there is there is no any fixed number. It is totally depend on the case, and you have wonderfully given example of that particular patient whose blood pressure, if it is used to be normal in two digits, 90 or 80 or 70, and if it is increased to 135 or 85, even though it is not fulfilling the criteria of hypertension as per the international guidelines, but uh, that patient can still have some issues and can reach to the level of target organ damage. Fantastic. Really appreciate that. So, considering the very broad topic, we have many questions. You have already answered most of them, but then again, there are many more. So, please allow me to take them one by one. So, my questions, it is up to you, speakers. You both can reply to the questions. Now, the first question is that, as you have mentioned, that there should be average of three different readings for of the blood pressure for the diagnosis of hypertension. So, these three different measurements for how many hours, days, or months apart they should be.
Okay, so thank you very much. That's an important question. In fact, when I was talking about it, I knew this question will come up. Okay, now it depends on the blood pressure level. Okay, if a young lady comes to see me, blood pressure 150, 52 over 92, I can give this young lady maybe 2 weeks to come, and then I'll check again, and then if it's confirmed, then I can give her another time. Okay, and say, well, lifestyle modification, come again. So the lower it is, the more leeway you have to ask the person to go and even monitor at home and come and see you. Now there are instances that people come with a blood pressure of 195 over 135. Okay, that's what we call urgent hypertension. Unfortunately, such a person, or even 230 over 140, such a person, I don't have the luxury of time to say, look, go and come back. What if this young man who is 42 years with a blood pressure of 195 over 130 goes home, starts exercising, or probably and in real life goes to have sex? And then what happens during the sexual activity? This gentleman's blood pressure goes to 300 over 144 and then gets a stroke. So I will use a day to confirm this blood pressure level in this person whose blood pressure is so high, who has severe urgent hypertension. So the level will determine how some people will come today. I say, come tomorrow, let me check it again. For example, the person is 178 over 120. Then I can say, okay, the following day, or wait in the evening or in the afternoon, and I'll check it again. So that question is important, and the answer is that it depends. Some patients you have leeway, to measure over a longer period of time, and can even let them monitor at home. But for some who come with a severe hypertension, hypertensive urgency, I would rather want to confirm that, over the same day, than to ask the person to go home, because the person may not come back again alive. Thank you.
Yeah. Thank you. Ma'am, would you like to add to the response, please?
Well, he has answered, Dr. Odoku as he's been doing since, has answered the question. The other thing will be to find out whether you can actually get associated hypertensive organ damage, hypertensive mediated organ damage. Maybe you do urinalysis, you find protein, or you can do ECG and you find LVH at that sitting. Since you have that, you can start the patient on treatment because you already have evidence that their hypertension is already affecting the organs. But in the absence of something concrete like that, you can wait till, like Dr. Doku said, evening to the next day.
Yeah, I think
Yeah.
what you said, doctor, is very, very important. I mean, if somebody comes in and has already target organ damage, then that blood pressure the person has is needs attention. And that if the person can afford to do all this within a day, when the person can really be important way of knowing that yes, this blood pressure the person has actually caused problems. So then one that will tell you, that can confirm that this person has high blood pressure, and second, that can also tell you that the person needs a treatment for it. Thank you, Dr. Olunuga.
You're welcome, sir.
And Dr. Doku, as you briefly mentioned about white coat hypertension, and you said that that's why home blood pressure monitoring is more reliable, ambulatory blood pressure monitoring. But sir, considering the ground realities in Africa, how practical it is for most of the patients to measure blood pressure at home. Will they afford it? Will they do it correctly? Or or we all should rely on other stakeholders in healthcare system, where they can go and check their blood pressures.
Okay, so I think I see there are few barriers to blood pressure checking at home. I think the gold standard is to check the blood pressure at home. Um, I think we can't suggest to the patient if the patient says, "Okay, I can't afford it," and most health insurance do not cover it. So, yes, the patient is claimed. Some also you can go, look, go and discuss with your family, maybe your daughter or your son may probably want to, or your husband may want to buy it for you. So that discussion needs to go on, not to just say that the patient cannot afford it. Let's look at options. So once the person is able to procure it, then you look at how does the person measure it. If the person cannot measure it, then spouse or children or even a neighbor can measure it for them. The other option will be, look, we have a lot of community pharmacy who have the BP machines, the fixed manometer over them. They could just, in fact, if some of them feel more comfortable with their community pharmacy, community clinics. Some have a clinic nearby and they know the nurse. So they are more comfortable with the nurse than coming to see Dr. Duku in the hospital that with all the stress associated with it. So there are several ways I think going around it. And I think if the person cannot afford the machine, person cannot check himself, community pharmacy, community hospital, community clinics really are much friendly environment where patients can go. You know, the other thing is when you go to this community pharmacy, what I have come to realize that the mercury fix really has a lot of, it's not being phased out because of the toxicity of mercury. But the other thing is that there's a lot of, you know inter and intra-operator variability. So the automated machines are now the way to go. you know. So the hospitals across Africa, we need to aim at using these automated machines, which are not dependent on the nurse or the doctor's, expertise to be able to get this right. So the automated one, one is easy to use and easy for everybody to use, and then the measurements are more reproducible than the mercury one, where it depends on how well you inflate, how fast it deflates, and the techniques for detecting the first sound and the fourth and the fifth sound, of course, and that is so I think the automated one is key. And then so it's all depends on patient can afford, or there are several other options, but the most important thing is that we should aim at home BP monitoring or community BP monitoring. Thank you.
Thank you, sir. Ma'am, as far as CV risk is concerned, which CV risk tool or CV risk assessment tools you would recommend to the audience?
Thank you very much. The simplest risk estimator to use is the WHO risk charts. Is the simplest. It's a chart, so it's on a table, and on top you see the blood pressure levels, the different blood pressure levels on the x-axis. On the y-axis, what you will see will be the risk factors. It will tell you the level of blood pressure, whether the blood pressure is normal, whether the blood pressure is associated with asymptomatic disease, whether the blood pressure is associated with symptomatic diseases. Then it tells you the risk factors, whether the patient has one or two risk factors, the first layer. The second layer, whether the patient has three or more risk factors. The third layer, it tells you whether you have some complications like hypertension, like diabetes, like chronic kidney diseases. Then the last layer, it tells you whether there are associated clinical conditions like diabetes. Diabetes will occur in 3 and 4, or whether the patient has had myocardial infarction. It's the simplest. And it's also based on different regions of the world. We have the one for Africa. It's the simplest that we can use, and you can make it available. You can paste it on your door. You can have it on the table and discuss it with the patient. Sometimes in Africa, we underestimate the ability of our patients to want to actually have a heart to heart talk with us, and we underestimate their ability to want to cooperate with us. They actually are also, is their life. We're talking about the patient's life. So the patient should be interested in his or her life. And to some extent, they're also interested. So we can carry them along. We can give them the chart. They can also, when we discuss how to use the chart, they can take it home, and it helps them to even want to work on the risk factors. We'll calculate the number of risk factors they have, and we'll tell them if you can move from 3 to 2, you will move from, maybe now you are in high risk, you can move to moderate risk, or you can move to low risk. So it's the simplest to use in this part of the world.
Okay.
Yeah.
Thank you. Let me just add, Doctor, thank you very much for the explanation. One other thing I see in Africa is some patient can come with a very high blood pressure, 200, or 230 over 140. And if you look at the chart here, it shows something high. But as I mentioned, most of these charts are try to detect atherosclerotic risk. But atherosclerotic cardiovascular disease in Africa is evolving. So you have a 25-year-old with severe hypertension. That high blood pressure is really a major risk. And that blood pressure can lead to hemorrhagic stroke, heart failure, and can lead to kidney failure and all. The same way an African with diabetes and is not controlled has an accelerated, somebody with a very, familiar dyslipidemia with very high risk. So let's look at the risk score or the chart to detect the person's risk of cardiovascular disease event and all that. But we have individuals with isolated, high risk factors. That also very, very important, especially hypertension. So there's no way to say, okay, an African 35-year-old with a blood pressure of 190 over 150 or 130, and then you look at the charts. Your age is, you are young, your cholesterol is normal, your sugar is normal. Looking at the charts, okay, your risk is somewhere here. That person probably will die the next day from very severe hypertension. So the risk charts for us is the WHO one is very important. Just also look out for people who have isolated severe, you know, elevated individual risk, because then they have accelerated, complications that develop within short period of time. Thank you. I have a patient who's had diabetes for now, let's say about 55 years. This gentleman had so much family support, and then he lately had some, diabetes mediated target organ damage. But on average, an African with diabetes within 5 years start having blindness, cellulitis, having this, having that. Even though the chart says, okay, the chart just picks the diabetes, but we don't know how well this diabetes is controlled. Okay, so on the chart, diabetes is yes or no. But what is within that diabetes is key. Does it have diabetes, peripheral neuropathy, diabetes, vascular disease, peripheral artery disease? Does it have retinopathy? Does it have this? Does it have that? There's a lot within that diabetes that can lead to death, even though the charts may not be able to bring it out. So let's look at the individual African with certain risk that they risk themselves. Today I check a patient of mine, the hemoglobin A1C is 12 and has been 12 for a time. And then today he said, look, it's been high for a while. So this person, even though the child will say diabetes, that diabetes is not well controlled for several years. The person will have accelerated. So just to add what doctor has said, let's also look at the individual risk and how well they are controlled, even though the child may not be able to pick the level that, and be able to assess the risk properly. Thank you very much.
Thank you so much, doctors. Next question is about the treatment part of hypertension, which is related to the ARPs, and question is about the place of telmisartan, how it is different from other ARPs.
Okay. I don't know whether you want me to answer that.
Ladies first.
Okay. The place of telmisartan. Um, telmisartan is an ARV that I love using for hypertensives. Now, note what I'm saying for hypertensives, not for my heart failure patients. If you have hypertension and I have to give you ARV, it's going to be telmisartan. And ask me why. Because the half life of telmisartan is 24 hours. When you're talking about the treatment of hypertension, you need a drug that will control that hypertension for 24 hours, especially the vulnerable time, which is the early hours of the morning. That is when you have most cardiovascular events. So anytime I have a drug that I will use for 24, that has actually that will actually work for 24 hours, I'm usually very happy with that drug. And that is one of the reasons why telmisartan is my favorite ARB for hypertension, not for heart failure. For hypertension, telmisartan is my favorite ARV because of that. If you look at, especially when you combine it with some other drugs like amlodipine has a half-life of greater than 30 hours. And if you combine it with diuretics in blacks, we know we have volume dependent hypertension. So if you combine your telmisartan with a diuretic, you know you have a winning ticket. And that is also because in most cases, we know that when we have hypertensive cases, in most cases, they already have other hypertensive mediated organ damage. And for most hypertensive mediated organ damage, compelling ARV is one of the compelling indications. Yeah, the hypertensive mediated organ damage is compelling indications for use of ARV. So you need ARV. Is the patient diabetic? You need ARV. Does this patient have um, um, stroke? You can use ARV. Does this patient have ischemic heart disease? ACE inhibitor is preferred, but in the absence of that, if the patient cannot tolerate your ACE inhibitor, you can also use ARV. And for many, if it is heart failure, I don't use telmisartan. One of the reasons why I don't use telmisartan for heart failure is because some of my heart failure patients, we need digoxin. And if you use telmisartan and you combine it with digoxin, there is potentiation of digoxin toxicity. So that is why in heart failure patient, I don't use telmisartan. But in my practice, we have a lot more hypertensive patients everywhere in the world than heart failure, because hypertension is what will lead to heart failure in about 70 to 80% of our patients. Hypertension is the cause of their heart failure. So telmisartan is a win-win drug for me any day, anytime for hypertension.
Yes, also to add that, yes, when it comes to the metabolic profile of telmisartan, very, very good. If you have a group of patients who have hypertension, hypertension and diabetes are related. Hypertensive become that also develop diabetes in the course of the disease, and then the diabetes have hypertension in the course of all because of the relationship between the renin angiotensin adductor system, the sympathetic system, and insulin resistance. So that is a key mechanism there driving diabetes towards hypertension, driving hypertension. And so the telmisartan, yes, has if we have a follow a diabetes hypertension for a period of time, person may develop diabetes. And telmisartan is able to reduce that that chance of the person developing diabetes. Again, left ventricular hypertrophy is very common among hypertensive. And telmisartan is able to regress the left ventricular mass over time. So that for me is very, very important. Okay, patient with nephropathy, telmisartan over time is able to also reduce nephropathy, the proteinuria, albuminuria, and all that. So the blood pressure control, as my colleagues just mentioned, the metabolic profile, the tolerance, the long half life, and then also several other things that makes it very an important partner in managing hypertension in Africa. Thank you very much.
Thank you so much. Our next question is, what is the main cause of the heart pain with clear or normal heart rate, normal blood pressure, X-ray and ECG?
Okay, all right. Let me take this. I think when was it? Last Thursday, I gave a talk to my team on chest pain. We started a series for the next few months, and then I took on the chest pain. No, there are several things that can cause chest pain. And as I started, I said that when a patient has chest pain, the first thing the person think of is the heart. Everybody is afraid of the heart. But there are several things that can cause chest pain. So there are chest pain that are life-threatening. There are chest pains that are not life-threatening, but they are urgent, and there are chest pains that gives you time. So we have chest pain from musculoskeletal diseases, um, also chondritis, chest pain from trauma, So that can cause chest pain. And you need to examine this person. You need to listen to the history that can give you an idea of what is causing. Now, you can have chest pain from gastrointestinal problems, peptic ulcer disease, um, from other gastrointestinal problem, esophagitis and all that. Now, you can also get chest pain from irritation of the pleura, for example, from pneumonia and all that. Get what we call pleurisy. So some of these chest pains are not life-threatening, but some of the life-threatening chest pain, unfortunately, will be the one due to pulmonary embolism, one due to aortic dissection, where you have severe uncontrolled hypertension, for example. Then you have this sudden tearing chest pain that goes to the back, that you think you're just going to die. That's very common. And you also have chest pain from heart disease. Okay, one common cause of chest pain in Africa is hypertension. Hypertension can cause chest pain, and you exert yourself, you have chest pain just because of one. Um, you have the hypertension causes atherosclerotic disease, causes coronary artery disease, not because of atherosclerosis, but because of the coronary arteries have becoming tortuous and because of increased pressure in the left ventricle. Okay, so that can cause some form of chest pain. But we also have chest pain from stable coronary artery disease, where you have atherosclerosis, where you have demand and supply mismatch. Of course, you can also have chest pain from acute coronary syndrome, where there's a plaque rupture, the thrombus formation that can cause unstable angina. You can have end-STEMI or non-ST elevation myocardium. So several things can cause chest pain, and the age of the person is important. The circumstances is important. So you need to take a good history. You need to understand this patient and be able to even assess the person's risk of having this and that. But majority of patients with chest pain are really non-life threatening. They're due to some tenderness, due to the bone or peptic ulcer disease and all that, and it can come up. So it's not every chest pain that's life threatening, but majority of them are really benign. You have to evaluate that person. And you need to assure that person, because the person is afraid, thinks the person is going to die. And even just putting your hand on the chest, it's painful. Some of them are chest pain, which is due to the cervical spondylosis with radiculopathy, with the pain coming into to the back and all that. And the pain is actually coming from the neck, and everything is blamed on the heart. So there are several ways, but just assure the patient that this pain is not likely it's coming from your heart. Um, but let me evaluate, and then you examine, we do some basic investigations, and then you'll be able to come out with the diagnosis. I don't know whether Dr. Uh, Unuga can add something, because it's a very common problem, chest pain. Yes.
Thank you very much. For cardiologists, chest pain is very common. You come across it. And the beauty of chest pain is, even for the primary physician that is in the village, if you can take a good history and examination, you, in 90% of cases, you make reasonable diagnosis, even when you don't have all the investigations in the world. Taking a good history and examination, if you can characterize that pain from what you have in your textbook on how to characterize pain, you can make a very reasonable diagnosis. It's very Chest pain is something I enjoy discussing with my patients, even without ECG, without anything. We can talk about it, we can talk around it, and both of us will know that it is not coming from your heart. Before the patient leaves, the patient will know that this is not a heart problem. And I will tell you why it is not a heart problem from what you have said, from the patient's discussion. what you have said, this cannot be from your heart. The duration, the location, you are touching it, patient is having pain. You can't be touching the chest and the patient is having pain and it's the heart. The distance is there. So there are structures before it. And just like Dr. Doku said, there are so many causes. There are over 30 causes of chest pain. But if you take a good history, the good thing about chest pain, in medicine, never say never. But the good thing about it is if you take a good history, in over 90%, you are not likely to be.
Thank you. Dr. Doku, you initially mentioned that recently this pandemic due to COVID, it also has some effect on heart, and there are some publications in this regard. And you mentioned that it causes myocarditis. It has been seen in some patients. So, this myocarditis, doctor, how long generally it lasts in such patients, and what could be the right treatment for such condition?
Okay, thank you very much. I think heart involvement in COVID is not very common. I mean, most of our patients have mild to moderate disease from COVID. Very few people have. But having said that, we've lost significant number of patients from heart complications, not necessarily from direct myocarditis, but mainly from arrhythmias, where patients develop arrhythmias and then they die suddenly. But a number of them also have perimyocarditis. Okay, some have pericarditis, some have myocarditis, some have both. Perimyocarditis. In fact, recently, about a month, no, 2 weeks ago, we had a 30-year-old who came in with severe chest pain that was worsening. The ECG showed typical, changes that are simulating a STEMI. I did the echo, which also showed that yes, a segment of the heart was involved. And then we did the cardiac markers; they were still high. So in such a situation, okay, you look at it: is it a STEMI or is it myocarditis? I think for a resource poor center, what you need to do is look at this person's age and look at the risk factors. Really, very risk factors for atherosclerosis cardiovascular disease is low. So what you can do is manage this person as STEMI or as myocarditis, and then most invariably for the myocarditis, yes, there are several things that you can give for this patient, but for COVID, there are COVID specific treatments available that can be given. And then the worst part of myocarditis is when they come in with a cardiogenic shock. Some of them can go into frank heart failure. Some of them can have all kinds of arrhythmias. Some of them can have severe hypotension that needs to. So what we do is manage patients in an intensive care with inotropic support, dobutamine, and then slowly. Some we can give steroids to reduce the inflammation, and slowly they build up. There are COVID specific medication, but a lot of our patients cannot afford it, so we just go more conservative with simple drugs. That dexamethasone, for example, some of the patients respond to dexamethasone, some with cortisone and all that. So you can give this medication and slowly monitor. The key thing is the low the hypertension and the arrhythmia that you need to look out for, that some of them can cause sudden cardiac death in these patients. Dr. Taiwo.
Okay, thank you, Dr. Doku. For COVID, it's something relatively new. And initially, there were discussions to and fro about the use of ACE inhibitors and ARBs because of the ACE receptor, saying if you use these drugs, the probability of dying, mortality from COVID will be increased. But that has been debunked. And we know that for our patient that has been on ACE inhibitor or ARB before COVID, even when you have COVID, you can continue with your drug and it's not going to affect the the morbidity or mortality from COVID. We also know that there's something now called long COVID because they are beginning to evaluate patients that has had COVID and they survived it, and they've been able to live for over 1 year. We've had the disease for close to 2 years now. So we have patients that are being followed up, and we know that some of these patients are beginning to show complications. Pulmonary embolism is also some of the features seen in COVID. And over time, some of these patients have developed chronic uh, 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 chronic pulmonary embolism with effect on the right side of the heart. When you do echo, you see some of these effects. And not just that, the arrhythmias, for some people, it's been persistent. We also know that the psychological effect is also there. For some patients, they come back to you complaining about cardiac problems. But when you actually evaluate after COVID, that is after the COVID infection, they come with cardiac complications. But when you actually evaluate, you realize that there's no cardiac complication, but they have this psychological problem that is taking time to resolve. So there are so many features associated with long COVID, and over time, with time, we'll get to know a lot about it. But we know COVID has come to stay, whether we like it or not, and it has some effect on the heart. But it's evolving, and as it evolves, we'll get to know more about it.
Thank you so much. We have full list of questions. I would like to pass on my sincere apologies to the audience that I couldn't take all the questions, because this is quite a vast topic. And don't worry, as I have mentioned that this is a hard talk series, right? So we will certainly address these questions maybe in future episodes of Hard Talk. And I would like to pass on our sincere thanks to Dr. Doku and Dr. Olunuga for this wonderful presentation. uh, I have learned a lot personally from this wonderful interaction from the experts, and we already have started getting fantastic feedback from our live audience. I would also like to thank our audience for joining our programs regularly, and for subscribing them in advance. And would also like to pass on thanks to the professional bodies. They have provided accreditation for this program. So audience, stay tuned to our alerts for the future programs. Thank you so much.
Thank you.
Thank you.
Thanks.